Good morning, everybody. I am Judd Hollandar, Senior Vice President of Healthcare Delivery Innovation at Thomas Jefferson University. And today we're going to be talking about adopting a new workflow for effective healthcare delivery. During the talk, I'll be taking questions through the chat function on your video. What we know about healthcare in 2020 is that patients want care when and where they want it. They now look at care as something that should be convenient and easily available. At the same time that patients are more commoditizing healthcare, it actually also turns out so are the payers. So payer healthcare is changing, and there is less fee-for-service. There is more shared savings or shared risk. You are all familiar with terms like the AAA, CPC Plus, and alternative payment models. And we are moving from what is a per-click payment model to a value-based payment model. And each of you in your health systems have to make a choice. You have to try to time the change, and you can stay with fee-for-service for as long as you want, but as you hit some precipice value-based care, you would have to make that change on a dime, or you can prepare for the change. In both cases, health systems wrestling with when and how to do this will lose some revenue. The question is, will you lose it up front by giving up fee-for-service dollars as you prepare for the change, or will you lose it when the switch occurs because you're not prepared for the change? And as we were wrestling with this, then along came COVID. I used to give this talk and focus on myth busting. I used to try and dispel these 5 myths. My patients don't want it. It's not as an in-person visit. You can't examine the patient. It's too hard, and it's not reimbursed. I think if you've been functioning during the pandemic, you easily know that most of this is not true. So I can now reduce that whole talk to one other slide. With respect to patients don't want it, you have seen that many patients do want it, and many actually like it better than an in-person visit. With respect to the concern that it's not as good as an in-person visit, data clearly argues otherwise, and I will show you some of that data. But think about it. Not every patient has the opportunity for an in-person visit. Some would have no visit or might get only a phone call, and telemedicine is certainly better than both of them. You can't examine the patient. That's hogwash. You totally can examine the patient, and it certainly does, again, better than no visit or a phone call. In fact, I'm not saying you should be doing this, but you can do a level 5 physical exam. It's not reimbursed. That is a real issue in most places pre-COVID, not so much of an issue during the public health emergency, but may actually be an issue once again after the public health emergency has ended. And the claim that it's too hard is just silly, because if you're a clinician, you do this with your family all the time. And if you're someone who knows a clinician, you do it with your friend who's the clinician all the time. So we've been doing this since they invented the iPhone, more or less. So this is a summary of the Jeff Connect program for illustrative purposes about how we can deliver care around the acute care spectrum and chronic care for that matter. But if you look at the inner gray circle, a patient's at their baseline. And the first thing that happens when they fall off their baseline is they get a little sick. If they don't get better, they get more sick. If they get sick enough, they show up in the emergency department. About 25% of patients in the emergency department get admitted to an acute care setting. We do a great job with almost all of them. They go home through a post-acute care phase and go back to their baseline, or maybe a little bit slightly lower baseline. And before COVID hit, we had grown out the programs you see around the circle to deliver care virtually to patients before, like I said, even before COVID. Now, a lot of the payers have focused on the right side of this wheel and post-acute care and avoiding readmissions. At Jefferson, we decided to focus a lot on the left side of the wheel, with the premise being the best way to avoid a readmission is to avoid the first admission. But if we start at 1 o'clock, you'll see one of our programs, and our first program was a neurostroke specialty network, where we extend the expertise of our neurosurgeons and neurologists into 38 community hospitals to rapidly evaluate stroke patients. We grew out an acute care program called virtual rounds. This was the really simple concept that doctors round on patients when their families aren't there, and families have no idea what's happening. So why not patch the families into the room via video so they can be part of rounds and have a better understanding? From 4 to 7 o'clock, we were delivering care through both primary care and specialty services. Post-discharge and when patients fell off their baseline, you could do a scheduled visit with your provider so they could take care of you. At 9 o'clock, we have the Jeff Connect on-demand app, which in our region, which is Pennsylvania, New Jersey, and Delaware, anybody could download from any of the app stores and see an emergency physician 24/7, 365 right away on demand. And then we have this concept called the virtual emergency department, which maybe you see me or my colleagues in the virtual emergency department, and you need some testing, but rather than send you to the bricks and mortar emergency department, we would coordinate that testing. And finally, when you come into the emergency department for real, we would have a remote physician or a remote APP seeing you. They would open your medical record, they would take your history, do a brief physical exam, write a note, order your x-ray, and order your labs. So by the time you got out of the room, some of your test results would be back. So that was about 2/3 of our program, but gives you an idea of how we built stuff all around the care continuum. Now, I'm going to show you some data, and I think it's important to frame it. The National Quality Forum created a framework to support measure development in telehealth. And so as we at Jefferson look at data, we use the 4 domains that NQF came up with, which is access to care, financial impact and cost, experience, and effectiveness. And we present our data on all our use cases in that framework. I'm going to begin by showing you our on-demand data. This was one of the early programs we grew out. And what we found is we're giving great access to care. 40% of the patients who came to us were new patients to our system. So it was great for new patient acquisition too. And 83% of these patients would have sought care elsewhere, meaning there's not much new utilization because 83% of people were going someplace, and every place is more expensive than telemedicine. The financial impact and cost amount to a savings of about $100 per encounter based on what patients would have done before the telemedicine visit, or if it wasn't there, having the telemedicine visit, and then what happened afterwards. Our experience surveys are phenomenal. Our Net Promoter Score varies between 70 and 90 in any given month. Patients obviously save time, they're going nowhere. But my favorite piece of data is that 80% of patients at the time of the survey, a week or two later, not would recommend, but had already recommended Jeff Connect to their friends or colleagues. And we have looked at effectiveness a variety of ways. The one I talk about is the first one, and this is antibiotic stewardship using the Choosing Widely guidelines for sinusitis. And the same physicians who work in our emergency department and our care work in our on-demand telemedicine program, and they did at least as well, if not better, in complying with the guidelines via telemedicine than in in-person care. Patients said their health complaint was addressed as they hoped more than 90% of the time. And 3/4 of our patients required no further care after the telemedicine visit. 5% are sent to the emergency department, and 2/3 of that 5% are either admitted or get a procedure, suggesting we are not over triaging to the emergency department. I want to show you an example of our tele intake program. And this is the way we evaluate patients when patients come into the ED, but the provider is not in the ED.
Hi, Mrs. Smith. I'm Dr. Joshi. I'm your triage doctor today. What brings you into our ER?
I have a fever. I'm a cancer patient who's currently going under chemotherapy.
Are you having any cold symptoms, such as cough, congestion, runny nose, or sore throat?
No.
How about any urinary symptoms?
None.
Joe, can you put the stethoscope on Miss Smith's back for me, please?
Of course, doctor.
Miss Smith, take a deep breath in and out through your mouth for me. Miss Smith, I'm going to order blood, urine, and an x-ray for you. And then you're going to go into the back of our ER where you'll see my colleague who will determine the best course of action for you. Do you have any questions for me?
No, I don't. Thank you for seeing me right away. This was really cool.
You're welcome. I hope you feel better soon.
Thank you.
So our tele intake program with respect to access to care, you're seen right away. I already described the way the program works. Our time to physician is between 9 and 14 minutes. Financial impact or cost, we reduce left without being seen, which generates more revenue for the hospital and more safety for the patients. Experience is rated by everybody as extremely high. Effectiveness, like I said, we reduce left without being seen, door to provider times, door to discharge, and door to admit times. So a very effective program that we're growing out in our health system. With respect to our scheduled appointment program, we provide access to care with over 1,400 providers, more than 400 before COVID. We're doing this regularly. I believe I'm going to show you some data that there's a decreased cancellation rate when people have virtual care compared to in-person care by about a 30% relative reduction. Financial impact can allow for increased turnovers and increased staffing efficiencies. Experience, great net promoter score, time saved, significant, of course, and over 40% already recommend Jeff Connect at the time of the survey, and 86% said they were better able to receive care. 83% saying they received the same level of care as an in-person. So very good data across all 4 domains. Now, we have studied this in multiple different specialties, including primary care. This is another primary care study. This is college counseling. This is the sinusitis study looking at adherence to quality indicators, urology study, a study in pre-surgical, pre-admission testing where our case cancellation rate was actually 0, in ENT, in surgery, and in emergency medicine. So this can work across multiple specialties. Virtual rounds program, which I described for you already, doesn't improve access to the patients, but improves access to their families, which we learned is critically important during something like COVID. Financial impact doesn't cost us a lot. We're probably not making a lot of money from this. In fact, I doubt we're making any money from it, but the feel-good experiential component is great, and maybe that drives some new business. And we don't have any effectiveness data on this, but it is well loved and well appreciated by the patients who choose to use it. I mentioned our neurosurgery network. We're in 38 hospitals with a 12-minute response time. Financial impact and cost depends on what's being measured. Our experience is great. 80% of patients are left in the community. They don't need to get transferred to the mothership downtown, which is fantastic for family visitation and the community experience. And we get to educate providers at the outlying hospitals with the expertise of our tertiary care providers. We have demonstrated that we increase the rate of consultation by experts, we increase the rate of TPA administration, and we actually have better functional outcomes at 3 and 6 months for stroke patients. So that works very well. In fact, that works so well that we developed the mobile stroke unit, which is an ambulance in one of our EMS services, which you could see in the top right has a CAT scanner within the ambulance, and in the bottom right, a telemedicine console at the foot of the ambulance. And this month, twice, we gave TPA within 20 minutes of picking up a patient. So we've done very well in taking care to the patients rather than patients to care. And then along came COVID. And we published this about how COVID is really the perfect way to launch telemedicine, although it would have been nicer if we did it without COVID, to tell the truth. And so I showed you the Jeff Connect wheel already, but what we did in COVID is we grew out the on-demand platform because we realized while patients were afraid early on to come to the emergency department, to come to urgent care, so to come to appointments, we could still deliver care to them via our on-demand platform. We leveraged our virtual emergency department concept by making our on-demand platform the funnel for COVID testing in our region. So you would call, be evaluated, and either go on home quarantine or get set up for testing, depending on your symptoms, your exposure, and whether or not tests were available, which we've been fortunate and we've relatively had most of the time in our region. We moved our tele intake model out to tents in front of the emergency department so we could send people away from the emergency department after a medical screening evaluation. We might be able to get care someplace better for them that's safer early on in the pandemic. We leveraged interprofessional collaboration, which I'll talk about in a minute, but is a way to do the informal drive-by or curbside and have an expert look at films and make it formal, and I'll explain that in a minute. We grew an inpatient telemedicine program so that providers who are at home could get in to see patients in the inpatient setting, so that if they were quarantined, we could still use their expertise. We leveraged our virtual rounds experience so that we could allow family to be virtually in every room with all the COVID positive patients and PUIs. We leveraged remote monitoring so that we could discharge COVID patients from the emergency department with pulse oximetry and still follow them. And really importantly, we stayed with our scheduled visits, and I'm going to show you a lot of data. So even though people were afraid to leave their house, we were able to take care of most of the patients that had a scheduled visit during this time frame. And then we developed the COVID-19 chatbot so we could actually be more proactive with getting patients evaluated quickly through the chatbot and upgraded to either telemedicine or an in-person or an emergency department visit as needed. So this is our data from one of our practices in New Jersey. The blue line represents the monthly goals, and we were fortunate before COVID. We were trying to get everybody in our health system to do a handful of telehealth visits a month so that they would be prepared as we switch to value-based care, and they would be prepared to care for patients who might not be able to make it in. So the blue line represents a relatively modest goal, just so people would be familiar with it. We were running ahead of goal on the orange line, but you could see we jumped from about 120 visits a month to 6,000 in this particular practice. This is our Department of Medicine at Center City, and COVID hit us mid-April, and you could see they were doing between 800 and 1,000 visits a day at the beginning of March, and a very small number in brown were telemedicine visits. As we pivoted, we were able to maintain 2/3 of the visit volume to take care of the patients, but 90% of them were telemedicine. And we see this in this month with the Department of Medicine, and we now see this in a weekly plot with family medicine, where they made the same change that our internists did during March, but we have maintained about 20% plus of our visits being telemedicine out to the last month or two. This is surgery. Just want to point out that green line is the percent of patients who are telemedicine, also running about 20% now, when it was a single-digit percent before COVID. So telemedicine is here to stay, and we need to adopt new workflows around it. This is how we get our inpatient telemedicine, and this is so simple, it's unbelievable. All we created was a dashboard and put tablets in rooms. You log on to the Jefferson website if you're a Jefferson provider. In the green box at the bottom left of this tip sheet, you select the hospital, then you select the floor, then you select the room, and you hit enter, and the patient in the room makes the connection so that you're allowed in the room. That's it. So I could be a doctor at one of our 14 hospitals and see patients at all 14 hospitals in any room that has a tablet. Very simple concept. And then we made this so patients can engage their families using the same tablet, and their family could stay on 24/7, 365. Well, luckily it's not 365, but 24/7. This is the interprofessional collaboration I mentioned to you. And this is the CMS definition. So it's effectively when a patient's treating physician requests the opinion and or treatment advice of a consulting physician without the need for face-to-face contact with the patient. So the consulting physician will review the chart, review the x-rays, talk to the physician caring for the patient, and put a note in the chart with formal recommendations. And this is a great way to expedite care and also allow physicians who may not be able to get to the site of care to deliver the site of care. So we've grown that out. I do think it's important to understand that telemedicine has a slightly different approach, and you need to establish rapport with the patient and have them see you and develop website manner. So you have all spent a bunch of time on your web conferencing software, and you've gotten used to seeing a lot of the top of people's heads because they tend to look where you are on the screen and not make eye contact with the video camera. So learning to deliver care has some sort of technical things that are different in terms of website manner. And I'll show you in a minute, lighting is one of them. But remember, telemedicine is not about delivering different care. It's just a different care delivery mechanism so it's the same care. Sepsis patients get the same care. It's just a matter of how to do it. So looking at the patient and delivering care by website manner is important. And it has some simple things like where you sit. Here's an example of what I call the glare. The window should be closed in the background. Worse than the glare is the angel of death, where you just look like a black amorphous blob. The ceiling fan in the top left, when that's spinning, that gets patients dizzy. Bad idea. Happens a lot, actually. This is not so bad other than the doc is squinting, but an LED light in front of you shows your face. You can make good eye contact and have a good interaction with the patient. That is important to establishing rapport. With respect to examining the patient, Osler said over 100 years ago, 95% of it's in the history, which you get over the phone alone. For the other 5% of information that's important, family and caregivers can help. Patients can do a lot on their own. We take care of a lot of asthma, heart disease, abdominal pain, back pain. You just need to get good at doing these things. It's not really that hard, but the first step is realizing I need to do it rather than, oops, I should just make them come for an in-person evaluation. And if you just assume, play the game with yourself that you need to do it, you'll figure out how to do it. But I also ask the question for you to think about, how good is the inter-rater reliability of the physical exam? And if you look at most of the studies, it's actually pretty bad. So telehealth, as I mentioned, is simply a care delivery mechanism. Our obligation is to provide quality care. I think we can all agree that it does not matter whether the care is provided on the 3rd or 5th floor of a medical complex, is documented in Cerner or Epic platforms, is performed by a physician who's wearing contact lenses or glasses, or whether the patient lives nearby or far away. Similarly, it should not matter whether that care was provided via telemedicine or in person. Quality care is quality care, and that's our goal. And this is a critically important point. So as we start delivering more telemedicine, we need to move and mature from adoption-based metrics, number of people that do a visit, to more quality-based metrics. And I'm just going to show you a couple examples here. So this is real Jefferson data that we published in that article. Our time to go to first appointment from when you first access what we call our Seamless Access Center is 19 days in person across all specialties, but 9 days via telemedicine for a 53% relative reduction. The amount of after-hours appointments that we give is 26% higher. The same-day cancellation rate is 31% lower. And add to that, the same-day no-show without a cancellation rate is 29% lower. So we improve access and we improve speed to care if we're using telemedicine rather than in-person care. I am going to point out that the same-day cancellation, 4% absolute difference, same-day no-show, 4% absolute difference. That's 8% more patients through the door. That's 1 in 12 patients show up when they otherwise wouldn't have shown up. But that does not drive up expenses when you talk to payers in your region, because the total work RVUs and the total E&M RVUs in primary care are down 30% in telemedicine. It's a little more efficient. Specialty care, total RVUs are down 54% because less procedures get done, and E&M work RVUs are down 13%. So this is a bigger reduction in billables than there is increase in access. So this is win-win. We could take care of more patients and not drive up costs. So I think it's important as we move to the end to point out that telehealth is not about the technology, it's about the workflows and operations. There's lots of platforms you could use to do telehealth. It is a care delivery model, not a type of care. We deliver the same care, just in a different manner. The medicine is the same. We need to get out of this headset that we're comparing it to in-person visits, because I just showed you 1 in 12 people wouldn't show up in the last day for an in-person visit, but will come for telemedicine. You are doing a physical exam. And then there's the really important realization that you might actually get more information than you do in the office setting, because we talk about social determinants of the health, but nothing is better than seeing where the patient lives and how they live and what the house looks like, and actually looking at the medication pill bottles to really do med reconciliation. And then finally, understand you don't need to get every diagnosis right, because you don't in the family medicine offices, and we don't in the emergency department when we first see people. We need to see people and get enough actionable information to know what test is needed, and then we need to order the right next step. So it's much more about actionable information. And that's really the same as you do in the office-based setting and hospital-based setting. So we have talked for a long time about reimagining healthcare, and I think we need to move from reimagining to actually recreating healthcare. Now is the time we need to create it. COVID, a horrible thing for our society, has given us insights into how we could go forward better, and we need to take advantage of it. For those of you that are sitting in the audience watching this and saying, this is interesting, how am I going to do this? There are a range, it's not just at Jefferson, but there are a range of training programs available to you at Jefferson at what we call NECTR, the National Center for Telehealth Education and Research. We train staff from the MA level, pre-med level, med students, residents. We have a 1-year physician fellowship. We have outstanding online CME and modules on how to do the physical exam, a Center for Digital Health and Data Science, personalized tailored programs for people at health systems who may want to come shadow our teams for a while, a consulting service, and then actually master's and soon to be PhD programs through NECTR. So there are places you could go. This is just one of them, but I think it's time for us to move forward. And like I said, we need to stop reimagining and we need to start recreating healthcare. And I will stop there. Thank you so much for attending this lecture today.